Hi, everyone, and thank you for the invitation to come speak with you today, and thank you for the kind introduction, Dr. Gartner. Can everyone hear me okay? I tend to have kind of a quiet voice, so if I start to not project, let me know. So as Daniel said, my name is Rachel Wilbur, and my academic background is really interdisciplinary, so my work tends to draw from the theories and methods and approaches of each of those disciplines, and you'll probably see that throughout the talk today. So today I'm going to dive kind of briefly into the causes of the health inequities that we see for Indigenous peoples in the Americas and give some ideas about what we can do about it from an academic and research lens. And at the end, there's going to be time for discussion, and I'm really looking forward to hearing your thoughts and perspectives. I don't get a ton of opportunities to speak with epidemiology and biostatistics audiences, and so I really appreciate thoughts and feedback. So throughout this talk, I'd really appreciate if you could keep in mind what you've been told about Indigenous peoples and our health so far in your lives, and keep in mind the research methods that you've been taught and how they may or may not produce the outcomes that we hope to see within public health spaces. But before I begin my talk, I wanted to acknowledge that this seminar is taking place in the unceded Anishinaabe traditional and ancestral homelands. And in order to go beyond lip service to reconciliation, I'd like to invite you to join me in learning about the Anishinaabe tribes, learning about their cultures, what they want for their people, and to participate in community events that are open to the public. So powwows are a super good example of this, and they're really fun. But to respect sovereignty and autonomy at all times. So it's important to remember that we are guests on these lands and to learn about our hosts. So this is a general outline of what I'm going to be talking about over the next 45 minutes or so. I'm going to start off with just a little bit of background information, definitions, and things like that. Some of this may be review, but I always find that it's best to be explicit about who and what I'm talking about. I'm then going to shift to talk about some of the upstream contributors or social determinants that contribute to the current state of Indigenous health inequity that we see in the United States. And then I'm going to move on to talk about some of the potential ways that we can address these health inequities through engagement in traditional cultural practices, before ending on an example of ways or a way that strengths-based narratives of indigeneity can be harnessed to support well-being. So I'm going to start by providing just a really brief introduction to the Indigenous peoples of the United States. So according to the 2020 census, 9.7 million people in the United States identify as either American Indian or Alaska Native, either alone or in combination with another identity. And this makes us 2.9% of the US population. Despite the common perception of American Indians as residing exclusively on reservations, today more than 3/4 live in urban or residential areas. Age distribution of American Indians and Alaska Natives in the US is younger than other groups, with around 28% under the age of 18. The First Peoples of the United States include an array of distinct cultural, political, and racial backgrounds, and there are a number of terms that are used to refer to them. So while these terms are often used interchangeably, each has a specific definition that carries unique implications for policy and practice. So I'm going to run through those briefly on the next slide. I think it's really important to keep these terms in mind because as epidemiologists and biostatisticians, you have the opportunity to use these terms in your data collection if you're conducting primary research, but you'll almost certainly use them if you're conducting secondary analyses of large population-based data sets. And in your reporting of your findings, you should be able to be clear about who exactly was represented in your data set and what that means. So one of the most common terms that we see in health research and practice is American Indian and Alaska Native. This is the terminology that's utilized by the US Office of Management and Budget, or the OMB, and it's therefore used for official federal data collection and documentation, including on population surveys like the US Census. So on its own, American Indian refers to Indigenous peoples of the lands covered by the lower 48 states, while Alaska Native comprises the Indigenous peoples of Alaska. You'll often hear Native American as well, and this is a more broad term than American Indian and Alaska Native, because it also includes Native Hawaiians, Chamorros, and Samoans. Indigenous and Native are generalized terms that are often used to refer to First Peoples. So Indigenous can be inclusive of peoples globally or Indigenous peoples in the US from other places. Native is more colloquial, everyone has their own preferences, but I tend to use it when I'm speaking informally. Both Indigenous and Native can be used, but Indian on its own is pejorative and should be avoided. This map comes from nativeland.ca, which is a project that aims to document the traditional and contemporary territories of Indigenous populations around the world. There's a lot to unpack in this map, and it's a really great website that I'd recommend people digging into if you have time and interest. But what I wanted to explicitly get across is that each tribal nation has its own unique geography, culture, history, religion, and language, and that they don't coincide with contemporary geographic boundaries. So the idea of referring to all of these peoples as a homogeneous group is not only inaccurate, but if you're thinking about factors that can impact health or health care, it could be very harmful. For example, many of the factors that impact health for Aleut up in Alaska are very different from the contributors to health for Navajo in New Mexico. So each tribal nation or community has a specific name. We'll both have a name that they're called by others and one that they call themselves. So whenever possible, it's preferred to refer to Indigenous nations by their own names. So for example, my family is Talawangchetco. We're down here. These are the names that settlers and now the federal government call us. They were derived from nearby tribes' word for us. We call ourselves the Dene, or the people. It's important to recognize that in addition to Indigenous nations and peoples that have a political relationship with the US, there are also Latinx Indigenous peoples and Indigenous peoples from other lands who reside in the US today. So in order to keep this presentation somewhat focused, I'm going to talk exclusively about American Indians and Alaska Natives in the US, because that's where my expertise is at. But I want to acknowledge this population is not representative of the entirety of Indigenous peoples in the US. At this point, I need to clarify something that's often misunderstood, but which has profound implications for Indigenous health research and practice. So American Indian and Alaska Native, as well as First Nations, Inuit, Métis, if we're talking about folks up in Canada, these are socio-political, not racial designations. So this fact impacts well-being directly through avenues like policy, but also indirectly through things like research methods and government reporting, as well as resource allocation based on these reports. Millions of Indigenous peoples inhabited North America prior to contact with Europeans. They created vibrant societies and systems of government that included diplomatic practices, justice, healthcare, and resource management. Therefore, in the US, tribal sovereignty predates the formation of this country. So this unique sovereign status is recognized by the federal government in the US Constitution through the Commerce Clause, which allows Congress to ratify treaties with tribal governments. So a basic understanding of this political context is critical. American Indians and Alaska Natives share a complex, unique, and constitutionally established relationship with the United States government that ensures inherent rights that are not derived from race or ethnicity. Federal law and policy distinguish between Indigenous and non-Indigenous peoples. So fundamentally, American Indians and Alaska Natives are members of nations with socio-political identities, not simply racial minorities. Because of this, tribes, states, and the federal government comprise three sovereign governing body types under US law. But despite having sovereign rather than racial status, American Indians and Alaska Natives are widely considered a racial group, and our health stats are compared to other broad categories of racialized peoples in the United States. So when we do that, the story that the data paints is that American Indians and Alaska Natives today are overrepresented in the federal justice and foster care systems and are underrepresented in higher education. So as I'm sure you'll recognize, these are social determinants that are closely associated with health outcomes. Because of this, despite American Indian and Alaska Native being a socio-political rather than a racial categorization, it's not possible to delve into issues of American Indian and Alaska Native health inequity without considering the impacts of structural racism. So prior to colonization, Indigenous peoples were healthy and living according to cultural values, worldviews, and traditions with land-based knowledges. Following European contact, settler colonial policies, and ongoing interpersonal and structural racism led to a crisis of health inequity for Indigenous populations. I want to stop here for a moment to define settler colonialism. So we're all familiar with the concept of colonialism, but settler colonialism is a specific form of colonialism that's been practiced in the United States and many other countries like Canada, Mexico, Australia, and New Zealand. It's when a country is colonized for land and resources, but instead of simply practicing extraction and leaving, the intention is for permanent settler colonies to then live on the land in perpetuity. Okay, so compared to other groups in the United States, American Indians and Alaska Natives experience significant inequities in health. In 2019, the average life expectancy for American Indians and Alaska Natives was 71.8 years, compared to 78.8 years for white Americans, and the COVID-19 pandemic hit Native peoples especially hard. Over the past couple of years, the average life expectancy among American Indians and Alaska Natives has dropped by over 6 years. This is a concerning statistic that's been attributed in part to social determinants of health, as well as a lack of access to quality healthcare. American Indians and Alaska Natives also die at higher rates from many preventable diseases like chronic liver disease and diabetes. So I could sit here all day and provide statistics that show inequity in health between American Indians, Alaska Natives, and other US populations, because it's a fact that Native folks statistically have the worst health statistics in just about every category. However, the narrative around Indigenous health is often focused on disparity. And instead of taking a deficit approach to talking about Indigenous health, which often implies or places blame on individuals or communities for the health that they experience, I want to focus instead on the structural and historical forces that have brought us to where we are today, because we cannot begin to address Indigenous health inequity without first understanding the upstream factors that contribute to it. So this is a quote by Danielle. Didn't let you know I put this in here. But you included this in a book chapter that we co-authored a couple of years ago, and it really stuck with me. So I hope you don't mind that it's here. But when we view statistics like those that I shared on the previous slides, they only tell us part of the story, and frequently without context and almost always without input from Native peoples. So it's really easy as health researchers to get lost in the numbers and to compartmentalize and separate them from the lives that are behind them. And I just want to use this opportunity to suggest that despite what we're often told, objectivity isn't necessary to do good science. So I mentioned a couple of slides ago that American Indians and Alaska Natives, that this is not a racial categorization. But despite being citizens of sovereign nations, there's still the reality of living in a society in which these pseudo-biological notions of race, often determined via arbitrary phenotypic indicators, differentially constrain opportunity. So while American Indian and Alaska Native is not a race, as a population, we are racialized by the Euro-American majority and experience racism and discrimination that have significant deleterious impacts on well-being. So historically, settler populations used racialized language and prejudice in order to other American Indians, and this eased the way for atrocities that enabled westward expansion. Later, federal policies used racially discriminatory actions to either maintain separation between Indigenous and non-Indigenous populations, like the inability to leave reservations without a permit, or in some states, segregation, or to force American Indians and Alaska Natives to assimilate into the mainstream US population. Examples of this include relocation or the boarding schools that we've been hearing more about over the last few years. So there are, of course, a lot of populations in the United States who experience racism and discrimination and who suffer adverse health effects because of these systemic and structural factors. When we talk about structural racism in Indigenous populations, however, we need to consider colonialism, which has been in effect since the 15th century. So with the establishment of the United States, the federal government explicitly sought the elimination of the land's Indigenous peoples through genocide, relocation, and assimilation. Policies and practices that perpetuate inequity have continued into the present. So given its temporal scope, colonialism is an ongoing structure of domination for Indigenous peoples, and it results in cumulative wounding across generations from both acute and chronic traumas, that make it a significant determinant of health for American Indigenous populations. So we talk about social determinants of health like poverty and access to healthcare, and for racially minoritized populations, we talk about structural racism as a social determinant. The American Public Health Association has been very clear on this for a while. But for American Indians and Alaska Natives, that structural racism is linked to settler colonialism. Health promotion and disease prevention efforts with Indigenous peoples and communities in the US must reckon with collective and enduring effects of colonialism and structural racism in order to improve effectiveness. The impacts of colonization on Indigenous well-being occurred and in some cases continue to occur through at least 3 simultaneous processes, including the introduction of disease, both intentionally and unintentionally, violent dispossession and erasure that occurred formally through policy, and environmental degradation. And each of these processes is rooted in colonial subjugation. The impact of colonizing forces and the dispossession of tribal lands has had sweeping impacts for all tribes across North America. And today, health scholars often characterize the impacts of these processes in terms of historical trauma and epistemicide. So the term historical trauma refers to the cumulative emotional and psychological wounding across multiple generations that emanates from massively traumatized group history. And within the Indigenous context, historical trauma events adhere to what is colloquially referred to as the 4 Cs. Colonial injury, collective experiences with cumulative effects, and cross-generational impacts. Epistemicide is a related idea, and it involves the destruction of knowledge undertaken as a tool of colonization, which has widespread implications for Indigenous well-being. This differs somewhat from traditional public health emphases on social determinants of health, which would attribute striking Indigenous health inequities to poverty or demoralization. And of course, a decline in health and well-being would be expected for peoples who are weathering circumstances of extreme deprivation or communal disruption. But for Indigenous Americans, these disruptions and deprivations in most instances were deliberately engineered. Specifically, Indigenous disadvantage has resulted from long efforts to intentionally dispossess, contain, control, marginalize, and erase. Therefore, rather than being attributable exclusively to broad social determinants like poverty, Indigenous community health inequities are the contemporary downstream indicators of historical projects of colonization. The historical trauma experience for American Indians and Alaska Natives is distinguished from other populations' experiences of historical trauma by its roots in colonialism, in that there is no post-colonial period for Indigenous peoples of the Americas. American Indians have not been welcomed to other countries as refugees of an acknowledged genocide. American Indians and Alaska Natives live daily surrounded by the physical manifestations of the trauma events experienced by our ancestors, from the continuation of the reservation system to the use of blood quantum to the regular desecration of sacred sites. American Indian and Alaska Native history since the period of contact has been overwhelmingly one of sustained cultural disruption and explicit destruction. There is no post-colonial era through which healing may occur. Research continues to document mental and physical health impacts associated with historical trauma events, often affiliated with some of the federal policies I mentioned earlier. And these are called historical trauma responses. These responses include anxiety, depression, post-traumatic stress disorder, substance misuse and substance use disorders, suicidal ideation, and elevated instances of chronic disease like diabetes, as well as indicators of later ill health like allostatic load. Importantly, experiences of historical trauma may contribute to, interact with, or amplify contemporary trauma experiences, which collectively exacerbates negative health outcomes. There are a number of pathways that have been theorized for the transmission of the historical trauma responses from one generation to the next, and they generally fall into two categories, social and biological. So psychological or social mechanisms include interrupted parenting, resulting in disorganized mother-infant attachment, or unresolved mourning or grief, resulting in challenges to relationship formation, as well as what's called a conspiracy of silence, in which experiences of a parent or ancestor are not discussed, leaving children or later generations to imagine what those experiences might have been, resulting in stress. Biologically, maternal stress and allostatic load have been found to have far-reaching and diverse impacts on the health of offspring, and both the experiences of mothers and fathers have been shown to impact the health of offspring through epigenetic inheritance. So there are a lot of, and I'm sorry, this is a really small visual, but there are a lot of Indigenous historical trauma models, but I particularly like this one by Kiermaier, Gahn, and Moses because it outlines the ways in which the intergenerational transmission of trauma can occur. But what's most striking about this model is that it clearly demonstrates that rather than past traumas as static events that somehow reach through time to continue to impact people today, as many people mistakenly think historical trauma theory implies, instead it shows that it's the experiences that we think of as historical trauma events, that they're the results of established systems that explicitly sought the assimilation and elimination of Indigenous peoples, and that it's this ongoing system of violence that continues to impact the daily lives of American Indians and Alaska Natives today at the individual, family, community, and Native nation levels. Because of this, it's the continuing impact of historical traumas. They may occur through biological systems like epigenetic inheritance, but they can also occur or co-occur through social or socio-political systems like forced family separation, which impacts parenting ability and access to social support, separation from food systems, which results in poor diet and chronic disease, and disempowerment, which limits opportunity and reinforces hopelessness, which stymies abilities to enact change. We can see the legacy of disadvantage experienced by American Indians and Alaska Natives stems from centuries of policies and actions with their basis in white supremacy. The impacts of the historical factors that I've talked about today, specifically events which are considered to be historically traumatic and which stem from federal policies, are compounded by contemporary racism and discrimination, which have long been demonstrated to affect health at the individual and community level among non-American Indian and Alaska Native communities as well. So both in adolescence and adulthood, there's evidence conducted among American Indian and Alaska Native communities, as well as with other minoritized populations in the United States, that perceived discrimination can act as a psychological stressor, contributing to lower self-esteem, depression, and psychological distress. So contemporary racism and discrimination compound the impacts of those historical traumas that I talked about earlier. Specifically, research has found an association between family histories of historical trauma and greater vulnerability to perceived discrimination, including in healthcare settings, as an ongoing traumatic stressor. Been further demonstrated that American Indian and Alaska Native inequities across multiple social determinants of health suggest that structural racism continues to impact American Indians and Alaska Natives at the individual, family, and community levels. That said, we're currently in a period of time in which Indigenous peoples and health scholars are actively engaged in shifting the narrative away from those which have traditionally been pathologizing. So historically, deficit-focused narratives and negative stereotypes for Indigenous peoples can be linked to European invasion. European reports introduced negative stereotypes such as Indigenous peoples as savages, which persist to this day. Such dehumanization was used to justify settler land theft and genocide via federal policies, as well as medical experimentation. Negative stereotypes about American Indians and Alaska Natives continue to pervade US society. And it's been shown that negative narratives and stereotypes have detrimental impacts on the provision of healthcare services, on American Indian and Alaska Native health, and on health research. There's increasing evidence regarding the harms associated with negative stereotypes on American Indians and Alaska Natives, particularly for youth, including impacts to self-esteem and psychological well-being. Language matters and helps shift narratives away from deficit, pathology, and problems and towards strengths, resilience, and active presence. Instead of focusing on health deficits, we can instead focus on Native survivance. So survivance is a term coined by Anishinaabe literary scholar Gerald Visner as an active resistance and repudiation of dominance, obtrusive themes of tragedy, nihilism, and victimry. And I'm going to delve into this more a little bit later. This work is being done in large part by shifting entrenched systems of power. When Indigenous peoples lead the conversations around their own health, the narrative is more likely to avoid colonial pitfalls and to embrace Indigenous strengths. So for health providers, this means the more Native doctors, nurses, and administrators there are, the more likely treatment is to be culturally appropriate and aware of systems of discrimination, which may be impacting the conditions that a patient presents with. In research, it means that instead of focusing exclusively on health inequities without context of their root causes, we can also look at how people have survived and thrived despite hundreds of years of colonial subjugation. Decolonizing the sciences is an essential way of addressing health inequity for American Indian and Alaska Native people. Broadcasting Indigenous voices of strength can be a tool to counter the dominance of historically traumatic experiences of Indigenous peoples. This approach also complements the work of strategic Native-led efforts to center community assets and counter dominant headlines and narratives that reinforce damaging stereotypes. There's a growing call to advance strengths-based approaches to Indigenous health research from Indigenous leaders, scholars, and practitioners, asking for research to build on existing community strengths and well-being. Indigenous scholars are leading the development of new frameworks that highlight Indigenous epistemologies and traditions and advance scientific research. I'm going to shift now to talk about what this means in practice. So in many instances, doing this work in practice involves the inclusion of Indigenous culture, tradition, and ways of knowing into previously mainstream or Eurocentric approaches to research. Euro-American health interventions, which are the norm in the US, have at times proven less effective when applied in American Indian and Alaska Native settings, and at times may even perpetuate harms. So Indigenous scholars and practitioners have suggested that interventions originating from Euro-American systems may be alienating or assimilative, and such interventions commonly fail to take into account cultural norms and expectations, including Indigenous perceptions of health and well-being, which encompass more than the self. So the concept of healing itself as an outcome of health interventions has been questioned by Indigenous scholars who suggest that approaches like this situate well-being on a continuum, which is incongruous with many Indigenous perceptions of wellness, and which places the onus for improvement on the individual instead of the structural forces that constrain opportunities for health. So if the very definition of health is different between populations, how can we possibly claim to be measuring it accurately? So there's instead strong evidence to support health programs and interventions that are community-based and center Indigenous ways of knowing. Approaches like these perceive healing as, quote, the spiritual revitalization of Indigenous orientations and practices, and often focus on the well-being of the community as a whole. One approach, which has been increasingly employed in addressing disparities in both mental and physical health within American Indian and Alaska Native populations, is the revitalization of cultural practices that were lost due to colonization. These efforts may involve the reconnection with land and language, encouraging a return to traditional foodways, and reinvestment in kinship systems of support and reciprocity. They may also bolster pride in Indigenous identity and community and encourage intergenerational engagement. So as a brief example, I'm going to really quickly summarize a study that I conducted a few years ago in which I sought to understand the role of cultural engagement and health promotion for an urban American Indian and Alaska Native population who had a family history of historically traumatic events. So specifically, I asked, how does engagement in traditional cultural activities impact the relationship between past generation, federal Indian boarding school attendance, and physical health with an urban American Indian and Alaska Native population? So I used 4 measures of exposure to boarding schools, family broadly, parent, grandparent, or caregiver. And study participant degree of cultural engagement was identified using a novel measure comprised of responses to 9 questions regarding traditional American Indian and Alaska Native practice and ceremonies that are common to tribes and communities across Turtle Island. So let's see, for outcome, I used a self-reported as well as measured physical health, which was analyzed continuously. What I found was that within this population, intergenerational exposure to historical trauma event to the boarding schools was associated with a greater level of engagement in traditional cultural activities, and then engagement in traditional cultural activities was associated with better physical health. So these findings indicated that despite the well-established role of the boarding schools in interrupting knowledge of and engagement in traditional cultural practices, participants in this study were finding ways to engage, even within an urban context. On the survey, it didn't allow us to elucidate the motivations behind this engagement, but we can hypothesize that participants or their family members who survived the institutions recognized the deleterious role of historical trauma in maintaining cultural connection and explicitly sought out ways to reconnect to their tradition and culture. I also found that engagement in traditional cultural activities contributed to improved physical health, and this supports earlier work in the fields of social work, public health, and psychology, which have found that engagement in traditional cultural activities has multifaceted benefits to both behavioral as well as physical well-being for Indigenous peoples. Few studies have been conducted among urban American Indian and Alaska Native populations, and so this was helpful to find that to see that this finding held within this context. So well-specific projects and interventions that incorporate what is often referred to as culture as medicine are important. Equally critical is shifting the overall narrative of Indigenous health towards one that is strengths-based. So I'm going to talk now about a current project I'm working on that decolonizes the language that we use to talk about Indigenous health, because the most notable fact about American Indian and Alaska Native health is not the presence of enduring inequities, but the continued existence of the people themselves. So approaching Indigenous health from a strengths-based lens means looking at the actions, practices, beliefs, and values that have enabled us to persevere and holding those up in ways that continue to support Indigenous thriving presence into the future. So one of the ways that we can do this is by looking critically at the language and tools that we use to measure and record presence, health, and well-being. So not only in the health sciences, we frequently use terms like resilience to denote the remarkable presence of well-being despite experiences of adversity. However, terms like resilience place the onus on individuals or communities to compensate for adversities that are experienced, regardless of the structural nature of the original threat. Furthermore, resilience is primarily focused on the individual and defines a person by their reaction to adversity, ultimately centering the event rather than the complexity of the human experience. And ultimately, resilience is a term that arose within Euro-colonial models that celebrate individual achievement over hardship, not an American Indian concept that works within Indigenous communities and cosmologies. So because of this, there's been increasing calls for terminology that derives from Indigenous ways of knowing, being, and moving in the world. Terminology that encompasses the Indigenous experiences, inclusive of both trials and successes, as a way of understanding where we are now and where we may go. So as I mentioned a little bit earlier, a term like this was developed by Anishinaabe literary scholar Gerald Visner in 1994. He started using the term survivance, which was a combination of the words survival and resistance, as an idea of a term that represents continuation through stories and active presence. Integral to the concept of survivance was what Visner calls manifest manners, and these are the static or inaccurate stereotypes of Indigenous peoples that are often recalled by resiliency narratives. Although it was originally applied within literary domains, the concept of survivance immediately gained purchase in disciplines like visual media, material culture, and education. Despite its popularity, the term then remained largely siloed, and its emergence in the social and health sciences has only occurred much more recently. So given the increasing appearance of survivance in relation to health, myself alongside other Indigenous health scholars decided to start developing survivance as a decolonized tool for application in Indigenous health spaces. So the first step of this project was to figure out how people are currently using the term. So back in 2022, we did a scoping review of survivance in the health literature. I'm not going to go into the details, the methods, or the frequency analyses of the scoping review. I just want to focus on the content analyses for right now, because it tells us how scholars are actually using the term in relation to Indigenous health well-being. So there were 5 key themes that pertain to the adoption of the concept of survivance that were identifiable across papers, and you can see them here outlined in red. So they were narrative, temporality, community, decolonization, and sovereignty. Essentially, this tells us that primarily Indigenous scholars are emphasizing the role of sovereignty and agency, particularly in relation to communities, as well as the ways we talk about our history and our future, and that all of these ideas are essential to understanding how American Indians have continued to survive and thrive, and how we may continue to do so into the future. So we've engaged in a number of other activities following the publication of the scoping review, including consultation with Gerald Visner, as well as numerous presentations and community conversations. And collectively, these activities have helped us to develop an idea of how survivance functions in health spaces. So we propose that health survivance is a proactive, strengths-based, decolonial construct that balances persistent survival with intentional resistance to the status quo, functioning at the level of community and culture to fundamentally shift the narrative from historical marginalization to ongoing thriving presence. Health survivance celebrates that we are still here due to the irrefutable strength of cultures and communities, which enables adaptation on Indigenous terms to perpetually and rapidly changing environments. Within health survivance, communal well-being is achieved through community strength and identity enacted via sovereignty, agency, and empowerment. The construct of health survivance illuminates the complex and interrelated factors that have enabled American Indians and Alaska Natives to survive across time, emphasizing factors like relationality, humor, and spirituality. The nuances of health survivance are unique to each community and are shaped by history, culture, tradition, politics, and relationships. So a few slides ago, I talked about resilience and why it may not be the best fit for a lot of Indigenous health research questions. Because of this, I think that it's really useful to compare and contrast health survivance and resilience, and I think that we can do this through 4 key differences. First, health survivance promotes persistence and thriving presence through resistance and contestation of the status quo by Indigenous peoples situated within the structure of settler colonialism and enacted via both overt and subtle actions. This resistance to the status quo differentiates health survivance from resilience in that it enables the transcending of systemic barriers that perpetuate health inequity. And these for Native folks could be the inability to practice culture, the inability to fish, the inability to protect water rights, rather than adjustment within the confines of an unjust system. Second, health survivance incorporates a temporal arc that is inclusive of the past, ancestral experiences, present or living communities, as well as the future, subsequent generations. So this arc integrates traditional knowledge and oral histories alongside contemporary socio-political and environmental realities to foster a sustainable and thriving future for upcoming generations. Importantly, this envisioned future is not a return to a romanticized or pre-colonial state. Instead, it's the generation of something new, reflecting the complexity of modern indigeneity. Conventional resilience, particularly that which is enacted primarily in response to acute trauma or adversity, and is aligned with mainstream conceptions of time as linear, is primarily concerned with individual adaptation of the present. And I know there's a huge body of literature around resilience and multi-systems approaches, and I'm happy to talk about those more at the end if you'd like. So third, health survivance is inherently focused on community and cultural persistence. Within health survivance, in keeping with many Indigenous practices, individuals exist as part of an interrelated whole comprised of relationships with people and other than human relatives around them. Because of this, well-being is collective, and community persistence is emphasized over individual survival. So while the primary emphasis for most resilience research remains on the individual in the present or the near future. Finally, health survivance fundamentally and explicitly refutes identities of victimization and vulnerability. Health survivance is self-determined by Indigenous communities, and it embraces collective knowledge, actions, and beliefs to uphold pride and tenacity in Indigenous identity. Health survivance is inclusive of systemic chronic adversity derived from ongoing settler colonialism and associated historical trauma, as well as Indigenous strengths. Because of this, health survivance includes acknowledgement of historical challenges and their role in contemporary lived realities, but it resists being dogmatically defined by them in perpetuity. This brings me back to my original discontent with narratives of pathology that I talked about earlier. So Visner refers to this as a reframing of Indigenous identities outside of erasure and victimhood that are wrought by colonization. So therefore, rather than being a reaction to vulnerability or a state of victimhood, health survivance is active resistance paired with collective recognition of what has been, what is, and what can be. Resilience often, but not always, incorporates a deep and enduring consciousness of adversity and trauma in relation to the identity and mentality of those who have been impacted and are therefore eligible to be resilient. So the next steps for this project, as of a couple of days ago, were being funded by the National Science Foundation. And they involve the collective and community-driven creation of a conceptual framework for understanding specific pathways that different communities have utilized to support their people's survivance over time, as well as the development of a health survivance measurement tool that could be tailored and employed by communities to track their survivance goals longitudinally. Collectively, this project represents Indigenous agency within a Euro-American healthcare and health research system. It's redefining our health goals and our ways of achieving them. So I think this is an example of what strengths-based approaches to Indigenous well-being are and how we can enact meaningful change within for the landscape of health in Indian country. So a lot of the work that I've presented is qualitative, but there are concepts, strengths-based concepts that can be applied outside of qualitative research as well. So a great example is epigenetics, and I've had the chance to talk with a couple of you about this already today. But briefly, epigenetics is the study of how one's biology and environment collectively interact to affect the ways that your genes work. Epigenetics literally means on the genes and refers to the placement of markers on your genome in response to behavioral or environmental stimuli. So these markers can turn genes on or off, changing how your DNA sequence is read. This has obvious implications for your health. So it's important to note that epigenetics does not change your DNA sequence, just the way that it's read. So all of us place epigenetic markers throughout our lives, and while most of these markers are wiped during reproduction, some of those markers are particularly enduring and are inherited by the next generation. Much of the research around epigenetics has focused on markers placed by particularly traumatic events and the study of negative intergenerational implications of trauma. So you can think about conversations you may have had or heard about the intergenerational transmission of trauma, and this is one of the ways that that's thought to have occurred. So common examples or studies that epigenetics have derived from are intergenerational studies following the Holocaust or the Dutch hunger winter. But as an evolutionary mechanism, it's equally likely that markers may be placed in response to actions, behaviors, or experiences that have a significant positive impact on an individual as well. So this has not been studied, and it's a great example of a deficit emphasis in medicine. I'm currently collaborating with scholars at Washington State University and a tribal nation in the upper Midwest to explore whether behaviors associated with survivance, like the preservation of traditional language and other traditional practices, including those that promote social support and traditional food systems, are associated with the placement of epigenetic markers. So study is an example of ways that Indigenous ways of knowing can be braided with Euro-American science to promote Indigenous well-being through a strengths-based lens. So I covered quite a bit today, and I just want to end by summarizing that Indigenous peoples of the lands currently called the United States are not a monolith. come from diverse communities with unique geography, culture, language, history, values, and expectations, and that each of these things has a profound impact on health and well-being. American Indian and Alaska Native is not a racial category, although as people we are racialized. We're citizens of sovereign nations, and this is critically important and frequently forgotten. Settler colonialism and the subjugation that derives from federal policies perpetuates the structural racism that is the root cause of Indigenous health inequity in this country. Historical traumas compound contemporary traumas and collectively impact the well-being of people today. Deficit narratives of Indigenous peoples and Indigenous health perpetuate these harms, while strengths-based narratives of Indigenous well-being may offer solutions. One of these solutions is engaging in culture as medicine, which has showed promise in both behavioral and physical health interventions. And decolonized approaches to Indigenous health do not automatically exclude the application of Euro-American science, just approaches Indigenous well-being from Indigenous ways of knowing. So effective approaches are likely to braid Indigenous and Euro-American science, since we all live in the contemporary world and many people walk in both. So I finally want to point out that although I've been emphasizing American Indians and Alaska Natives in this talk, a lot of this applies to other populations as well. Of course, common perceptions and stereotypes impact not only the type of healthcare that people receive, but how they are represented in research. And that has a lot of implications for people's well-being. So it's unlikely that many of you work exclusively with American Indian and Alaska Native populations, but I hope that some of what I've said today resonates with you in relation to the populations that you do work with, and may challenge you to think about ways that the stories we tell and internalize about the people and their health that we work with has real-world implications, and offers a few suggestions about what we as scholars and researchers can do about it. So I'd like to acknowledge that some of the things that I presented today were casually derived from a report that I co-authored a couple of years ago for the Robert Wood Johnson Foundation, and I'm grateful for the intellectual contributions of the folks on the screen. And that many of the ideas on which this presentation is based have resulted from years of collaboration with other Indigenous scholars and communities, and that it's important to acknowledge that I'm a product of my family and community, both natal and academic. I also want to acknowledge Drs. Joseph Gahn, Amanda Thompson for their mentorship, as well as Dr. Denise Dillard and colleagues at WSU who support this work. Visual ways for everybody.
Just cut off. Yeah.